Hello and good evening to all my dear students. Can you please let me know in the chat box if my audio and video is good? Right. So I'm just waiting for your comments so that I can start the session. Okay. So good evening, everyone. So this will be a very short discussion of the 10 MCQs asked in the Monday midday quiz. So Monday midday is an initiative by DocTutorials to conduct topic-wise quizzes of general medicine on every Monday at 9 p.m., followed by, again, a very crisp discussion at 9:30 p.m. for those 10 MCQs. So this time, the topic for the exam, in fact, there were two topics. One is the seronegative spondyloarthropathies, and second is crystal-induced arthropathies. So I hope the questions were good and you enjoyed the quiz as well. So I tried to put a mix of questions. Some questions were very simple, some on an average level, and a couple of them maybe you can say it is slightly difficult. Okay. So let's go to the discussion part of the Monday midday quiz. And I expect that in the comment section you can answer and you can let me know your thoughts for that question as well. So as I said, this is not going to be an elaborative discussion. This is going to be only a to-the-point discussion of 15 to 20 minutes. That's it. So do not expect a detailed test and discussion type of discussion for such sessions. The only aim is to guide you on how to come to the answer. Okay. So first question, false statement regarding acute CPP crystal arthritis. Okay. So what is CPP? CPP is calcium pyrophosphate. Okay. CPP is a calcium pyrophosphate. Calcium pyrophosphate. So calcium pyrophosphate related arthritis can present in acute form as well as chronic form. The acute form can sometimes mimic gout, which is why it is often called pseudo-gout. And the chronic CPP crystal arthritis often mimics osteoarthritis. So they're asking false statement about acute CPP arthritis. So first option is more common in elderly. Well, that option is actually a true statement. Okay, CPP arthritis is more common in the elderly population. So I'm not going to take that as the answer. So second option is increased levels of inorganic pyrophosphate. So in case of gout, we know that there is accumulation of uric acid, right? In case of CPP arthropathy or the CPPD disease, which is calcium pyrophosphate dihydrate disease, you will have increased levels of inorganic phosphate. And this phosphate will then combine with calcium to form calcium pyrophosphate. So the second option is also a true statement. So I am eliminating that option as well. Third one mimics acute gout flares. So I've just told you that acute arthritis can sometimes mimic an acute gout. So this is also not the answer. So coming to the last option, what do you think, Dr. Lakshmi, Dr. Bismi, Dr. Himasri, what do you think is the answer to this? So the last option is first metatarsophalangeal joint is most commonly affected. So though I told that an acute CPP arthritis can mimic a gout, the first metatarsophalangeal joint, which is the most common joint involved in gout, is very rarely only affected in case of pseudo-gout. So this is actually not a correct statement. In fact, the joint that is most commonly affected in pseudo-gout is the knee joint. Okay, is the knee joint. So the answer is option D. Okay, option D. So I hope we are clear with that question and let's move forward. And I can see most of you, Anirudh Bhadra, Manish, Lakshmi, Karthik, all of you have answered correctly. Question number 2. false statement regarding acute gouty arthritis. Options are cloudy synovial fluid. Option B, serum uric acid may not be always elevated. Option C, erosions with overhanging bony edges. And option D is X-ray shows double contour sign. So the question regarding acute gouty arthritis, see, cloudy synovial fluid is actually true, because in case of acute gouty arthritis, you've got inflammation, and the number of WBCs in the synovial fluid is increased. So normally you may have around 200 cells per millimeter cube in the synovial fluid. But here what happens is that there is a high cell count, often more than 5,000, because of which the synovial fluid in case of acute gouty arthritis is cloudy. So I'm going to eliminate this option, cloudy synovial fluid. Coming to the next option, serum uric acid may not always be elevated. Now this one is also a true statement. The reason is because, see, you would all expect uric acid to be elevated in acute gouty arthritis. In fact, it is correct that hyperuricemia is a prerequisite for acute gouty arthritis. But the issue here is, during the time of an acute gouty arthritis, we know that when the macrophages try to engulf the MSU crystals, this can result in release of several inflammatory cytokines. So the inflammatory cytokines involved in the acute gouty arthritis process also has uricose-uric action. Now listen to me carefully. These inflammatory cytokines can have uricose-uric action, which means when a patient presents with acute gouty arthritis to the emergency department, at that particular point of time, because of the uricose-uric action of the inflammatory cytokines, there is a chance that the uric acid might be slightly reduced than what it was maybe a few hours back. So you cannot always say that during the acute episode, the serum uric acid will always be elevated. So I am just removing this option as well, because this is also a true statement. The next one is erosions with overhanging bony edges. Now this is also correct. Now this is what we call it as the the Martel sign, and you can see areas of erosions which I'm marking with the red. You can see areas of erosions, and what I'm marking with green, which is also highlighted by the arrow, is that you can see overhanging bony edges. So you can have erosions with overhanging bony edges, and this is what is referred to as Martel's sign. So this is also a true statement, and hence that option is also eliminated. Now coming to option D, the X-ray shows double contour sign. Well, double contour sign is right. Double contour sign is a finding in acute gouty arthritis. But there is an issue here. It is not an X-ray finding. I have put option D as X-ray shows double contour sign. Remember, X-ray shows the Martel sign. This double contour sign is actually a sign that you get in the ultrasound. When you look at the ultrasound, you can have a look at this. So double contour sign means you can have an echogenic line on the outer surface of the joint cartilage, which is parallel to the subchondral bone. And this is actually occurring due to the deposition of monosodium urate crystals on the surface of hyaline articular cartilage. So what you can see in the arrow here in image is actually the double contour sign. So double contour sign is a feature of gout, but it is actually a feature in case of the ultrasound. So I'm going to pick option D as the answer. X-ray shows double contour sign. I just want to know in the comment section, how many of you got this right? Because I slightly put it in a twisted manner. I just want to know in the comment section, Dhruv, Anirudh, Hirdya, just let me know how many of you got it right. Right. So let's go to the next question as I'm awaiting your replies. Okay. Question number 3. Which urate lowering therapy should be avoided in patients with HLA-B5801 allele? See, the answer to this question is option C, allopurinol. So why is allopurinol avoided in patients who are having HLA-B5801 allele? The reason is because in such patients, there is a higher chance of severe cutaneous adverse reactions. And how do I put it in short form? SCAR. Severe cutaneous adverse reactions to allopurinol. You call it SCARs to allopurinol. which can range from minor rashes to Stevens-Johnson syndrome or toxic epidermal necrolysis. So in such patients, and also in patients who are having chronic kidney disease, there is a high chance that the patients may develop scar. Okay, so I hope that is also clear. So answer is option C here, allopurinol. Okay, because of the higher risk of allergic skin reactions. Coming to the question number 4, not a common pattern of skeletal affection in psoriasis. Asymmetrical oligoarthritis, symmetrical polyarthritis, migratory arthritis, and arthritis mutilans. Well, the first one, asymmetric oligoarthritis, is correct. Okay, you can have asymmetrical oligoarthritis pattern. Sometimes this can very well resemble another disease. Can you tell me which is the other disease that I'm talking about? Asymmetrical oligoarthritis. It can sometimes mimic reactive arthritis. Sometimes it can present with symmetrical polyarthritis. So then in that case, it is a very close differential diagnosis of rheumatoid arthritis. You must understand that psoriasis can have varied skeletal presentations. And the pathology of psoriasis is very similar to that of rheumatoid arthritis involving the synovium. So you can have a symmetrical polyarthritis like RA, and asymmetrical oligoarthritis like a reactive arthritis. A severe form of destructive arthritis is also known as arthritis mutilans, which is also a pattern of skeletal affection in case of psoriasis. So that is also a correct statement. Okay, it is also a pattern of skeletal affection. A couple of more patterns of skeletal affection can be there. One is a predominant axial involvement. So you can have psoriatic spondylitis as well. Psoriatic spondylitis, especially in patients who are having the HLA-B27 allele. Okay, so patients with the HLA-B27 allele, there is a higher risk of psoriatic spondylitis. And let me just ask you one additional question. Can you tell me what is the direct HLA association of psoriasis? I'm not talking about psoriatic arthritis. I'm just asking you, what is the direct HLA association of psoriasis? I'm just waiting for your comments. Now, the next point is, I told about the axial involvement. The another pattern is the distal interphalangeal joint involvement, DIP joint involvement. Now, this is also very important because DIP joint involvement is unlikely in case of rheumatoid arthritis. So when psoriatic arthritis presents with a symmetrical polyarthritis, if the patient has a DIP joint involvement, it is likely to be psoriatic arthritis. And remember, when you think of a DIP joint involvement, there are 3 important conditions that you should keep in mind. Number 1 is psoriatic arthritis. Number 2 is reactive arthritis. And number 3 is osteoarthritis. So in fact, these are the major patterns of skeletal affection. Migratory arthritis is not actually a feature. Migratory arthritis is actually a feature of acute rheumatic fever. So this one will be a feature of acute rheumatic fever. And so my answer is going to be option C. Okay, my answer is going to be option C. And yes, I can see, HLA-CW6. You can even call it HLA-C6. HLA-C6 or HLA-CW6 is the HLA with direct association with psoriasis. Okay, HLA-B27 is having an association with psoriatic spondylitis. In fact, all these seronegative spondyloarthritis, they're having an association with HLA-B27. Okay, I hope that is also clear. Next, coming to question number 5. So question number 5 is, among the following, the most likely radiological finding in reactive arthritis? Is it symmetrical sacroiliitis, spinal fusion, non-marginal syndesmophytes, or penicillin cup deformity? And I'm sure most of my students listening to this would have straight away eliminated option D, which is penicillin cup deformity, because this is a finding that is associated with psoriatic arthritis. So it is between the first 3 options. The first option says symmetrical sacroiliitis. Well, symmetrical sacroiliitis can be seen in reactive arthritis, but when you compare with ankylosing spondylitis, most likely the reactive arthritis is going to have an asymmetrical sacroiliitis. Ankylosing spondylitis usually has a symmetrical sacroiliitis, whereas this condition would have an asymmetrical sacroiliitis. Okay, so I'm eliminating that option as well. Next is spinal fusion. Well, spinal fusion again can rarely happen with reactive arthritis, but is very less likely compared to ankylosing spondylitis. So the spinal affection can be there. The spondylitis can happen in reactive arthritis, but the spinal fusion is less likely in case of reactive arthritis. And the final one, the final option is non-marginal syndesmophytes. Now, this one is actually a feature of reactive arthritis. When you compare ankylosing spondylitis and reactive arthritis, you see in case of ankylosing spondylitis, the syndesmophytes will be along the margins. You can see it is almost, just connecting the two margins. And this is called marginal syndesmophytes. This is actually a feature of ankylosing spondylitis. Whereas in case of reactive arthritis, you can see that the syndesmophytes are slightly away from the margins. Can you see it? It's not like in a straight line, right? It is slightly away from the margins, and it is also slightly more bulkier. And because it is more bulkier, it often looks like a comma shaped. It is comma shaped, or sometimes even people call it jug handle syndesmophytes. Comma shaped syndesmophytes or jug handle syndesmophytes. Okay, so keep that in mind. So the answer for this question will be option C, non-marginal syndesmophytes. Okay, I hope you're clear with that. Now coming to question number 6. Question number 6 is the first line, pharmacological therapy in ankylosing spondylitis. Again, a simple, straightforward dolly question. Well, in case of ankylosing spondylitis, all the options which are listed can be used in the treatment. So NSAID can be used. Infliximab, which is an anti-TNF alpha, can be used. In fact, infliximab is one of the most efficacious drugs available for the treatment of ankylosing spondylitis. Whereas when you look at secukinumab and ixekizumab, both of them are actually antibodies against interleukin-17A, and both of them are FDA approved for ankylosing spondylitis. Okay, both of them are FDA approved for ankylosing spondylitis. Secukinumab is actually a human monoclonal antibody, whereas ixekizumab is a humanized monoclonal antibody. So this is a human monoclonal antibody, whereas ixekizumab is a humanized monoclonal antibody. Okay. So the first line is being asked. So drug which is efficacious and with least side effects is often preferred as the first line pharmacotherapy, and the answer is going to be non-steroidal anti-inflammatory drug. Answer is option A. Question number 7, 30-year-old man presents with 1 week history of swelling of knee joint, low backache and bilateral heel pain. On examination, there were ulcers on his penis. He was treated for an urinary infection 3 weeks ago. What is the likely diagnosis? So the patient is having a relatively acute onset of symptoms. And patient is having pain in the right knee joint, low backache and bilateral heel pain. So knee joint means definitely a peripheral joint is involved. Low backache, considering an inflammatory condition with the other symptoms, this is likely to be due to spondylitis. This is likely to be due to spondylitis, considering the other symptoms as well. And bilateral heel pain is likely to be due to enthesitis. Now, enthesitis, spondylitis can happen with ankylosing spondylitis as well. But again, see the history. It is usually 1 week history. So it's relatively acute. Ankylosing spondylitis usually does not present like that. Reactive arthritis has an acute presentation. And also peripheral joint involvement, though can occur with ankylosing spondylitis, is not common. And again, such sort of an acute presentation is unlikely. But what takes us to the answer is the findings actually that is mentioned in the later part of the question. You can see some extraskeletal manifestations in the form of ulcers over the penis. So in the context of the clinical scenario, this could very well be a circinate melanitis. And to substantiate this further, you are having a history of urinary infection 3 weeks ago. So this could have been an infection that have triggered an aberrant immune response, resulting in a reactive arthritis. So answer is reactive arthritis. I would straight away eliminate chronic gouty arthritis because this is 1 week history. I would eliminate ankylosing spondylitis again because it's usually not having such sort of a presentation for the reasons that I've already told you. Acute gouty arthritis also I would eliminate because enthesitis is not a feature, low backache is not a feature, and it's usually not the knee joint, but it's a first MTP joint. Can the knee joint be involved in gout? Yes, but not common, but it can be definitely involved. But again, the classic presentation is a first metatarsophalangeal joint inflammation. Okay, so I hope we are clear with this. Dr. Sulekha Nain, Dr. Indrajit Raut, Dr. Mohammed Inam. I hope we are clear on this. Question 8, again, a simple, straightforward question. What is the most common extra-articular manifestation of ankylosing spondylitis? All the options given are extra-articular manifestations. In fact, the most common being anterior uveitis. Okay. Question number 9. Again, I just want to know how many of you got this right as well in the comment section. So 76-year-old male is referred for the further management of suspected ankylosing spondylitis. Okay, suspected ankylosing spondylitis. He was told that he had an abnormality in radiograph, and that radiograph is shown. He emphatically denies any sort of stiffness, pain, or enthesopathy. His examination shows slightly limited spine flexion and normal chest expansion. Inflammatory markers are not elevated, and he had no history of ocular disease or adolescent back pain. So the question is mentioning about a suspicion of ankylosing spondylitis. It is unlikely to be true because you can see one is the age of the patient. So we know the classical age group of ankylosing spondylitis somewhere is around 20 to 40 years. It is unlikely for a patient of this age to present with features suggestive of ankylosing spondylitis. And also you can see there is any sort of, there is denial of any sort of pain or enthesopathy. And though there is some sort of a limitation of the spine flexion, and but you can see the chest expansion is normal. So some sort of spine flexion abnormality is there. Now that is what is actually making us think, yes, are we having some sort of involvement in the spine? But normal chest expansion, because we know that in case of ankylosing spondylitis, there will be a reduced chest expansion because of the involvement of the costovertebral joints. Inflammatory markers are not elevated, again suggesting this is not a probably inflammatory disease. And there is no other, he had no history of ocular disease or adolescent back pain. So this is all taking us away from the diagnosis of ankylosing spondylitis. So, but this again points to a close differential diagnosis of ankylosing spondylitis. But again, when I say differential, it's rather than mostly clinical, it's radiological differential diagnosis, because clinical wise, it is relatively easy to differentiate, especially having the presentation at this age group. So what you are actually seeing here is ossifications involving the anterior longitudinal ligament. And these ossifications are actually in a flowing manner. It's almost like a flowing wax. Can you see them? It's almost like a flowing wax that you can see, the ossifications involving anterior longitudinal ligament. So this happens in a condition known as diffuse idiopathic skeletal hyperostosis, or DISH. This happens in a condition known as diffuse idiopathic skeletal hyperostosis. Diffuse idiopathic skeletal hyperostosis. Diffuse idiopathic skeletal hyperostosis, which is actually DISH. So this is actually a feature of DISH, or diffuse idiopathic skeletal hyperostosis. So DISH is the answer here. This is usually seen in elderly. The exact etiology is not known. Patients may have some clinical features suggestive of an ankylosing spondylitis, like a slightly limited lumbar spine flexion, but not sort of other skeletal manifestations or extraskeletal manifestations, and neither will be there any elevation of the inflammatory markers as well. So this you can see, this is what happens in DISH, sort of ossification involving the anterior longitudinal ligament. Okay, right. Coming to the last question, question number 10. Modified Schauber test is used to assess, is it chest expansion, is it thoracic spine extension, is it lumbar spine flexion, or is it thoracic spine flexion? So this test is often asked in exams, modified Schauber test. So this is used to assess the lumbar spine flexion. This is used to assess the lumbar spine flexion. So you very well know this test, wherein you are first marking out the two posterior superior iliac spines, and then you mark out a point parallel and 10 centimeter above it. Then you ask the patient to flex forward, and for a person with normal lumbar flexion, you should have an increase in the length, whereas in case of ankylosing spondylitis, which is relatively advanced, there is some sort of a spinal fusion and limitation of a spinal mobility, because of which you will not be having significant increase in length on flexion. So the answer is going to be option C here, lumbar spine flexion. Okay. So that's it. These were the questions for the, the Monday midday quiz. So I hope all of you were benefited, and thank you everyone in the comment section for the active discussion. Dr. Anirudh Badra, Mohammed Dinam, Sulekha Naeem, Sandra, Lakshmi, Hanina, Mudassir. So again, thank you everyone for joining the discussion, and I hope the quiz was useful for you. A quiz was useful if you got some new information out of this quiz. So every time, I conduct Monday midday quizzes, I try to include a couple of points at least, which I do not cover in my routine classes, so that, it's just for you to get an advantage. Okay, but I hope we are clear on this, and I hope there are no confusions as well. Okay, so I wish you all the best. Keep studying well. I know most of you are preparing seriously for the upcoming exams. Many of you are preparing for the upcoming INICT. Many of you are preparing for the NEET PG exam. Probably we might also have got final year MBBS students also giving these exams, but it's always exciting to interact with all of you. And I wish you all the best. And thank you so much, and see you sometime. Okay, bye.